a little bit about what were some of the findings from Track C, which was on epidemiology and prevention research. And so before I move forward, let me sort of also acknowledge some assistant rapporteurs who were with me at the conference. Elizabeth Bakusi was from Kenya. Kana Hayasi was from Canada. Howie Lim from Malaysia. Ruth Ann Marcus from the US. Mark Stuve from Australia. And Maria Veres from Brazil. And all of them spent a huge amount of time going through the conference abstracts. There were over 25 sort of group presentations related to prevention and epidemiology, and there were over 650 abstracts that were all reviewed and synthesized. And so I apologize if I'm not able to cover everything that was presented at this conference, but it was an incredibly busy and productive conference. So if I could just sort of give you an overview of what I'm going to try to cover during this time period, was that it was really loud and clear that prevention remains crucial for ongoing control of the HIV epidemic. And even though there were some discussions about whether there were competing interests with regard to prevention versus treatment, I think it was important to recognize that whether one uses the term treatment as prevention, treatment is prevention, or treatment for prevention, that these activities are indelibly linked. Unlike previous AIDS conferences where things like IPREX or other sorts of studies were presented, CAPRISA, etc., there were no big game changers, but there was really a fair amount of data that were presented that looks at the sustainability of some of our prevention efforts. And so I will try to walk us through some of the issues. There were a couple of innovations that I think are noteworthy, and I'll try to go through some of those. The first one was that there was a series of presentations from authors as part of the Lancet series, and part of the theme of the conference was looking at sex workers, whether it was male sex workers, female sex workers, transgender sex workers, and talk a little bit about this Lancet series, but it really presented some very important data of a key population that really has not received as much attention in the past. I think that we also got some insights into the external validity of studies that support PrEP, such as the open label extensions, and we also got to see some of the problems associated with an evidence-based prevention, such as mother-to-child transmission, from randomized controlled trials. And really, even though they were somewhat implementation science in terms of the analysis, it gave us some insights into how prevention may optimally work, or situations where it may not work quite as effectively. I think that there were a series of presentations of using treatment as prevention. As I mentioned before, whether you call it as or is or for prevention, they are indelibly linked. There were some interesting modeling studies that gave us some insights into what would potentially be best practices, and I'll present a few of these as well. And one of the really exciting things, even though it didn't really give us results that help us with regard to our own day-to-day prevention, was that we got to see some insight into trials that were forthcoming that may provide us some new ideas or new strategies about prevention. And then last, in terms of the overview, the inclusion of the voices of key affected populations were strongly represented at this conference, with the notable exception that young women, particularly under the age of 25, from sub-Saharan Africa, their voices were somewhat absent from the conference as were the voices of prisoners. So there were people who were representing them, but their own voices were not heard as part of panels, plenaries, and other sorts of findings. So to put things in perspective, we have a number of different interventions that are effective or that we hope to be effective with regard to HIV prevention. The Let me see if I can just change this screen slightly. And that we got some reaffirmation of interventions that are effective for people who inject drugs, such as needle and syringe exchange programs and opioid substitution therapy. Some additional data on mother-to-child transmission, specifically option B+. There was actually a fair amount of data, mostly from sub-Saharan Africa, on male circumcision, and we'll talk a little bit about that. There wasn't a lot of data on STI treatment, but nonetheless, as part of our armamentarium, there was some interesting data on HIV voluntary counseling and testing, specifically couples-based counseling. Not as much on behavioral intervention, a fair amount on treatment as prevention. One of the exciting things, even though there wasn't a lot of data, but there was certainly a lot of enthusiasm, especially with some of the satellite conferences, on the use of mobile technologies, especially in how we might sort of meet young adults and adolescents where they are. Not a whole lot on post-exposure prophylaxis, but a fair amount on PrEP, and not a lot this year on microbicides for women. I think if there was an overarching theme with regard to HIV prevention, there was a strong emphasis on structural HIV prevention, not only with regard to modeling, but some of the studies that included some of these structural factors. And I'll be able to go through them as we begin to think about what might give us some additional bang for our buck. So in a very elegant plenary session, if you get an opportunity to review it, Ken Mayer gave us a tour de force presentation on a number of new oral PrEP strategies. So this is the face of the future. We saw some preliminary data using PrEP on demand, and I'll show you some data from the open label extension of IPREX, looking at varying levels of adherence and its ability to prevent HIV. We also got some insight into some new medications, such as a number of new classes of antiretrovirals, as well as some intriguing, very preliminary data on monoclonal antibodies that might be used for HIV prevention in the future. We also were able to see some new delivery systems, such as vaginal and rectal microbicides, some intravaginal rings that also were that might be co-formulated with contraceptive barriers. That is the ability to kill two birds with one stone. There was some preliminary data on a couple of different classes on long-acting injectables that may be effective for as long as 8 to 12 weeks. And then some really interesting ideas if one sort of takes the idea of the breath mint, these sort of nanofiber films, these small little tabs that you can put in your mouth that would actually deliver a medication as prevention. So these are all the future delivery systems that we might be able to use for prevention. And then there was a fair amount of insight into male circumcision updates with some new techniques, and really the idea of task shifting, that maybe perhaps not requiring physicians to do this and using new tools to sort of expand the ability to expand this evidence-based intervention. We were unfortunately reminded that in the current funding era that prevention resources have remained relatively flat without a whole lot of evidence of increase over the next couple of years. There seems to be an increase in the amount of funding as it relates to treatment as prevention. Obviously, with the idea that we certainly don't lose other forms of funding in new areas. but there was some other areas that seem to be suffering cuts as we look at the sort of the future horizon in terms of funding for HIV prevention efforts. There were a number of epidemiological studies looking at female sex workers from almost every continent. Most of the settings showed relatively high prevalence of HIV, and in places such as in sub-Saharan Africa, it's even higher than the already high prevalence of HIV in the general population, where there's a generalized epidemic. And then there were some areas where we got some insights into the prevalence of female sex workers that was certainly lower than we see in sub-Saharan Africa, but they were numbers that were several-fold greater than in the general population, giving us some insights into where there might be sort of expanding new epidemics. And so this was an important theme across the entire conference, as mentioned previously. And I think it was repeatedly pointed out in symposiums and in plenaries and in poster sessions that there is an extraordinary amount of heterogeneity, and that there is not going to be just one prevention strategy that's going to work for all populations. And it was important to sort of disentangle the issues that may be relevant for female sex workers that might be very different than for male sex workers or for transgendered sex workers, all of whom had different epidemiologies, as well as potential insights into how prevention might work. And one of the things that was quite salient across a number of different presentations of female sex workers is that whether you're modeling or whether you're trying to enroll people or female sex workers in trials, that the issue of migration is particularly problematic. And this is especially true in Asia and Central Asia, where sex workers often move quite regularly, oftentimes in response to structural impediments such as police harassment and other sorts of factors that are in there. Now, one of the presentations that was delivered by Stephanie Strathy, but the lead author was Kate Shannon, who couldn't be there because she was delivering a child, was from the Lancet series. And one of the things that they did with this is they began to model, it's kind of a tale of three cities, but they began to model the ability to avert HIV infections or transmissions through structural changes. And they looked at whether or not you could eliminate a number of factors that occur commonly in the lives of sex workers, such as the exposure to violence or inconsistent condom use associated with condom confiscation, inconsistent condom use due to client violence, or whether social workers are able to create collectives and work together. I looked at other things such as increased antiretroviral coverage, peer or led outreach or sex work outreach interventions, or just creating safer work environments or changing the laws so that there's decriminalization of sex work in a given area. And in this study, they looked at three different settings with, and this is really the importance of the fact that one size doesn't fit all, but they looked at three different settings in Vancouver, Mombasa, and Bellary. And in each of these settings, the sex work scene is quite different. For instance, in the epidemic in Vancouver, it's a concentrated epidemic among sex workers with a fairly high prevalence. But even among the sex workers there, there's already a high antiretroviral coverage in that setting. And what seems to be present there is that combined frequent effects of client physical violence and police harassment, an elimination of just one of those would have a relatively low effect, as you can see in the green bars all the way across. But as you begin to combine some of the structural changes, such as inconsistent condom use associated with or due to climate violence, plus other interventions, you begin to start to have an impact. And I'm going to focus on the left side of this graph first. If you move over to Mombasa, in this setting, there's high levels of sexual violence that occurs and police harassment, similar to that in Vancouver. But there's low condom access and support, which is unlike Vancouver. In this setting, there also is a concentrated HIV epidemic with a very, very low antiretroviral coverage. And so here you begin to see antiretroviral coverage as an important contribution to prevent HIV infections, but also some of the structural even single and combination factors play an increasing role here. And moving on to Bellary, where there's really a low HIV prevalence, and so there's the potential expansion of an epidemic if it were introduced, if HIV were introduced. But what they have there is that the existing combination prevention and structural and community-led efforts are already in place, and so they've already had a huge effect in reducing violence, and so there's some communalization of the sex workers in Bellary, India. So unlike in Mombasa and Vancouver, which are very, very different epidemics, you don't really see a lot of these sort of small single-level structural interventions having much effect. But what you do see is that irrespective of the setting, that you're going to have the most bang for your buck, maybe perhaps except with the expansion of antiretroviral therapy to sex workers in Mombasa by sort of changing the environment so that it's a safer work environment for sex workers, and probably the most bang for your buck by decriminalizing sex work in these settings. And we're going to hear more about this as it relates to male sex workers a little bit later by looking at some other efforts. And so I think that this gives us some insight in terms of how we may think about prevention and sort of recognizing that that different environments may require some different strategies. Becker and colleagues presented another paper. Linda Gale looked at looking at vaginal microbicides, or PrEP, or using a test and treat strategy, or a combination of vaginal microbicides and PrEP, or all three of them together. And what they did from this perspective, this was sort of modeled in the Republic of South Africa. This is where there's a concentrated HIV epidemic with an extraordinary HIV prevalence that exceeds 50% among female sex workers there. And what they did was they looked at whether individual or combined prevention strategies would have an impact not only on the sex worker herself, these were female sex workers, by the way, or on clients. And you can see that that among the clients themselves, you'll have the most benefit by using a test and treat strategy, primarily on the basis of the high prevalence for the partners. So if you treated the sex workers, it would reduce the likelihood of transmission to their sexual partners by reducing the infectivity. However, combining vaginal microbicides and PrEP for sex workers would have some benefit for the sex worker herself, but that would be increased if you added on test and treat. So that the idea that combination prevention strategies, including microbicides, PrEP, and/or test and treat using treatment as prevention, all sort of combine together and sort of improve treatment outcomes using this modeling study. As promised, I would talk a little bit about male sex workers, and there was a really elegant study that was done by Catherine Oldenburg. And what she and her group did was they sort of mapped out where they could find data on the prevalence of HIV among male sex workers. And as you can see, there's various different concentrations from various different regions where they had data. And what they did was they went through and systematically went through the laws as it relates to human rights protections. And they had a very careful coding process. And they looked at multiple different models, and they included a number of different factors into these models. And irrespective of the model that was used, they found that there really portended about a 5.5 to 8% reduction in HIV prevalence for every human rights protection that was available in the country where they had the prevalence of HIV among male sex workers. They did an additional analysis where they used a Gini coefficient where they looked at the association of income, and they found that increased income for male sex workers was also associated with a decrease in HIV prevalence. So the combination of human rights protections, a structural intervention, and income, both are independent factors that would be associated with decreasing HIV risk, which leaves, as part of our prevention efforts, a lot of work by our human rights activists and attorneys in a number of these different countries in order to make some changes. Moving on to what is new among adolescents and young adults. Susan Cassidy did a really elegant plenary session on this that I would certainly recommend that folks see to sort of see the state of the art. One of the sort of sub-analyses that was presented there, but also in more detail in one of the oral presentations, was to look at adolescents in low and middle income countries. And for those of you who work with this group or look at the reporting, one of the things that we struggle with is that children are sort of defined as 15 and younger, and adults as 15 and older. And so that seems to be the cutoff. But what they did in a number of different analyses is they sort of redefined this young adult group, young adult and adolescents, to the 10 to 19-year-old group, and disaggregated these data. And what was really striking, and it has important implications for prevention, is that even though new infections had decreased in low and middle income countries by 37%, the mortality rate had increased by almost 200%. And it was striking because as they began to disentangle this, they found really remarkably different findings based upon gender. Whereas young girls had markedly lower mortality than young boys. This was primarily because the young boys were part of a birth cohort, and so they were living beyond infancy into sort of their teenage years, and unfortunately dying of complications of not continuing to have access to therapy, being lost in care. And this whole concept of transitioning children into, or adolescents into adult care remains problematic in several presentations around the globe, especially in sub-Saharan Africa. And also there tends to be, as we know with many sort of adolescents, the issue around adherence becomes increasingly problematic as they become more independent. The other explanation for why the girls had reduced mortality in this setting was that they were becoming infected at a young age. And so they were not symptomatic and not as ill, so they would have expected that the mortality would go up in about 10 years or so. And so really sort of identifying that there are differences that need to be addressed depending upon whether it is a young person who's transitioning into adolescence and adulthood, who was perinatally infected, or if indeed it is someone who is newly infected and moving into adulthood right from the beginning. There were other presentations, specifically an important one from the Republic of South Africa. And one of the things that I'm going to sort of hit upon a couple of places, and I know this isn't medications as prevention, but it's an important prevention data that were presented, but it's the idea of uh, 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 conditional cash transfers. And in one study in the Republic of South Africa, they did something a little bit different. They looked at a number of communities, and it wasn't conditional cash transfers, it was unconditional. In other words, they said that we're going to give both boys and girls cash because we really understand that poverty is an important piece of this, and it wasn't conditioned on whether people sort of changed their risk behaviors or didn't have STIs, etc. But what they then did was they looked at communities that got additional support, from teachers to keep young boys and girls in school, to have them provide better mentorship for students in this setting. But they also looked at expanding that into the communities as prevention by teaching parents better parenting skills, how to keep their kids also in school, how to sort of spend time with them, and how to motivate them to work. And what was different about this is among young boys and young girls, there were differences with regard to looking at a reduction in risk behaviors over time. And the finding from this was that giving cash alone was really insufficient to change the risk behaviors among young boys. But that for young girls, either giving cash alone reduced the risk of engaging in risk behaviors by 37%, but that was increased by providing this sort of care not only to parents and to teachers by 45%. So you get a sort of a synergistic effect when you combine them for girls, but really it was the sort of structural changes that were occurring at the community level that was having the most impact for boys. And even though the study was powered for STIs, HIV incidence itself decreased incrementally for each care component that was added. So there was an additive effect that occurred with doing more in the communities. The other emerging theme, even though we didn't have really nice, elegant clinical trials, but there was a really good session in the Global Village. It was called Like Me, Tweet Me, Post Me. And it sort of looked at using mobile devices and online technologies for youth HIV programming for prevention. And the sort of overarching idea was that youth really enjoy this. They did this a lot. But the program that they were putting in place had to sort of be overseen by some peer educator who kept things from going in the wrong direction, such as misinformation or sort of the attacking of other people. So it required some sort of monitoring in order to keep it in check, because these things have lives of their own. But overall, it was highly accepted. And even though it wasn't an empiric study, it gives us some insights that for this young population, everybody has phones. They're communicating with each other, and part of the future is going to be, using mobile technologies to sort of reach this population that has been traditionally challenging to reach. There were a number of studies looking at MSM, and it was broadly, we were sort of reminded to look at this as, once again, a heterogeneous group of folks who were gay, other MSM who don't identify as gay, and transgendered women. Beatrice Grinchen gave another really elegant and tour de force plenary session that is worth viewing. What she brought to our attention was the sheer magnitude and the impact of HIV, irrespective of the continent, in terms of new infections, and that there were incredible microepidemics in various settings with different drivers. There was a preponderance of new infections that were occurring, especially among young MSM, irrespective of the location. And so the need, once again, to sort of look at young adults and adolescents, but now adding on the group of MSM. There were some ecological modeling that she presented some very good data on, looking at not only individual contributors to HIV risk and transmission, but the setting, how criminalization and laws and policies really were major drivers, and how we need to sort of again think this is once again a theme looking at structural potential changes, and how these factors are syndemic, that is, they're mutually reinforcing and negatively impacting the HIV epidemic among MSM. Now, there was one modeling study, and I think that if we, as I begin to disentangle some of the data from the conference, I think it's important to keep in mind some of the findings that we see in low and middle income countries that are really in contradistinction from what we're seeing in high income countries, especially with the knowledge about treatment as prevention, perhaps the knowledge about serosorting, whether people are making those sorts of decisions. So we're going to see some different sorts of data depending upon whether we're looking at a high income or a low income setting. There was one not very nice modeling study looking at syphilis that was done in 3 countries in Europe. And what they were doing was they were looking at the increase in syphilis that was occurring throughout these 3 settings within Western Europe. And what they found is that syphilis transmission was greater in the HIV positives than in the HIV negatives. You can see in the graph to the right the modeling as it sort of increases with serosorting. The serosorting obviously resulting in the non-use of condoms with what were at least perceived as individuals of the same serostatus with HIV positive MSM serosorting with other HIV positive serosorting, but also resulting in increased syphilis, so sort of looking at the unintended negative consequences of reducing HIV transmission to others, but there are other STIs that may actually be associated with that. Prevention of mother-to-child transmission. Most of the data that were presented there really had to do with option B. There was an entire series of presentations that were dedicated to this, and the overarching finding is that option B plus, which is the idea that pregnant women get access to not only testing, but they get antiretroviral therapy, that antiretroviral therapy is made available to the newborn infants, and that the mothers continue with their antiretroviral therapy. So that's the plus, is that they're going to continue on it and not continue. But that overarchingly, there's marked improvements in antiretroviral access. One of the problems, and this is where the rubber hits the road with regard to prevention, is that the retention and care, this B plus component, retention on antiretroviral therapy for the women postpartum, it's just really remarkably low. There were a couple of presentations from Malawi, which looked at loss to follow-up at almost a quarter of the group of women who delivered per year after follow-up, which really sort of undermines some of the long-term treatment as prevention strategies that have been sort of recommended. And so the loss to follow-up was independently associated with higher age, not lower age, so we're not really talking about the younger women. Again, the distance from the clinic. And one of the sort of concerning things was that many of these women, as part of their antenatal care, were given the antiretroviral therapy and told to do it to prevent infection to the child. But when they followed up these women and asked why they didn't continue, one of the independent correlates of loss to follow-up was that they just didn't know that they needed to continue it. They perceived themselves only needing to take it in order to benefit the health of or to prevent transmission to their unborn child. So really leaving open the idea that we really have to somehow start the notion that it's not just for prevention, but it's for treatment of the individual. On the next slide, I'm going to talk a little bit about the great variation that occurs. So this is an implementation issue, but I think it's nonetheless has important implications for how we sort of perceive our mother-to-child transmission, but how retention on antiretroviral therapy may be based upon the way that the healthcare delivery is presented. So let me just go back. So in one study, what they did was they looked at the way that they looked at 4 different models, and one of them was all antiretroviral therapy was provided in the antenatal clinic, and um, and for this sort of model, you really have a fairly good outcome in that 82% of the women did end up getting antenatal HIV testing. So this model did the best with regard to making sure that women were tested so that they could actually go on to get treatment. The next model, which was where the antenatal clinic says, all right, we've tested you, and now if you need antiretroviral therapy, or not if you need, but you do need antiretroviral therapy, but we're going to send you to the antiretroviral clinic. Now, there was a significant proportion, about a third of those did not have antenatal HIV testing in that setting, but the retention in care really approaches 90%, so it was really quite high. And that the antiretroviral referral sites, where they didn't really provide antenatal care, but they were sort of just taking care of the of all antiretroviral therapy, irrespective of whether they were pregnant or not, had very similar findings with 90% retention 6 months afterwards. What seems to be present is that this second model, where they would first screen for pregnant women and send them, give a first dose of antiretroviral therapy, and then send them over to the antiretroviral treatment clinic, really resulted in the worst outcomes overall and was not sort of recommended. There were other factors that were went into the multivariate modeling, looking at why no antenatal HIV testing was done, and one of them has to do with just the staffing. So if you have many more clients compared to HIV testing staff, that was so basically just the burden was too great, was associated with decreased likelihood of testing. And then the availability of test kits was a single problem. When looking at the second outcome, which is retention for 6 months or more, some of the district locations played a point, whether it was rural versus a more urban community, and also individuals or clinic settings that had high patient volumes were less likely. Those were independent factors that associated with allowing our mother-to-child transmission strategies to be effective. So I sort of term this next idea, how do we turn a B plus to an A or an A plus? So this is what teachers and professors do. We grade our systems. There was a really interesting idea in Uganda that was the creation of a mentoring mother program. And it's a task shifting, and it sort of takes away the idea that the trained professionals, such as doctors and nurses, etc., would have the major responsibility for helping women get tested, helping them initiate antiretroviral therapy, engaging in antenatal care, continuing their antiretroviral therapy afterwards. So really the whole spectrum of holistic care. And what they really found is that the presence of the Mentoring Mother program increased a lot of psychosocial support and well-being of the pregnant women, both before and afterwards. It increased the likelihood that the women were HIV tested, not only for the mothers, but for the babies, and that they had higher retentions on antiretroviral therapy. So this can be a task-shifting, cost-effective way to improve interventions that we know are already effective, that have been documented in randomized controlled trials. The sort of limitation that the presenter shared with us is that in order for it to be most effective, it requires that there's excellent training of the mentoring mothers, and so that they have the proper information and motivation in order to be effective at doing their jobs. There wasn't a lot of new information on prevention among people who inject drugs, so there was relatively low conference coverage. There were a couple of sessions where um, uh, 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 individuals from various different regions would present updates on needle and syringe exchange programs and opioid substitution therapy to control the HIV epidemic. We learned from one of the symposiums that it's just really markedly poorly scaled in many regions, especially in Eastern Europe, Central Asia, and in many places also in Asia. So we're really having some problems, and we saw some evidence that there's emerging epidemics of drug injection and HIV transmission in sub-Saharan Africa and Tanzania and Kenya, and to a lesser extent in the Republic of South Africa, and that these regions are not poised and ready. We did see some findings of where model programs in Tanzania were being rolled out, so that was really exciting to see some of that. Um, it was fairly clear from a number of epidemiological studies that where there is low coverage of needle and syringe exchange programs and opioid substitution therapy, that there remains volatile HIV epidemics, and the example of Russia was set forward as a place that really has very few needle and syringe exchange programs and absolutely no availability of opioid substitution therapy, with one of the most volatile HIV epidemics that's transitioning into a generalizing epidemic. We learned that China, where they have rolled out a lot of patients on opioid substitution therapy, primarily methadone, is that there is still ongoing HIV transmission. This is primarily related to, despite the fact that there's a fairly robust response to rolling out methadone, the dose for methadone just remains remarkably too low, and there's inadequate social support to really provide additional services to be retained on methadone. And there were some data that were presented on the need for combining both of these in a number of different settings. Kate Dolan gave a sort of a broad overview looking at the extraordinarily low OST coverage and even lower needle and syringe exchange coverage in prisons. And she showed that as it relates to lower coverage with increasing amounts of incidence and transmission of HIV infections, really telling us that we have to take evidence-based prevention strategies and move them into multiple other sectors. But obviously that will have a number of other constraints, and so we need to learn how to become better at that. Some of the very exciting data on prevention came from the open label extensions of two PrEP studies. The IPREX study, Bob Grant presented, this is a study, a randomized controlled trial of tenofovir and emtricitabine for prevention among MSM, and as part of the open label extension, it was really, I think, important for many of us in the research community and the service delivery community to see that there was a very high acceptability, as evidenced by a high continuation rate. 76% of the patients who were in the study agreed to continue on afterwards. What was interesting is that the continuation was associated with people identifying as engaging in high-risk behavior. So it's the idea that the people who probably needed it most were making the right decisions. So that was another good sign. There was a couple of really important subcomponents to the presentation that I think was really important for us to see. And if there was any lesson to learn from this, is that the adherence must be good, but not perfect. So we've seen that sort of bar graph over time for irrespective of which PrEP study that has been out there, that you see this increasing preventive effect with increasing amounts of adherence. But the relative risk for reducing HIV transmission was reduced by 84% if individuals took their PrEP 2 to 3 times per week, and it was 100% if they took 4 or more doses per week. So this is not the 100% adherence. It's lower than that, and it as a proof of concept in an open label trial, I think it's very helpful for those of us who are working with our communities and with our governments to roll out PrEP, and the concerns about whether people will take it and those sorts of things. So one is it's acceptable, it's being taken fairly well, and it seems to maybe perhaps have a little bit more efficacy than we had thought at varying different levels of adherence. There was another sub-study which looked at dried blood spots of tenofovir, and one of them was a qualitative study that didn't show that there was a lot of risk compensation, that is, people felt safer. And among heterosexuals in Botswana, once again, a high continuation rate, and the risky people were more likely to continue. I'm supposed to really wrap up here, but let me just sort of say a little bit about couples-based testing, and that serodiscordant couples on PrEP require regular HIV testing. And the idea was that self-testing rather than supervised facility testing was feasible and cost-effective, so we might want to incorporate that into some of our PrEP interventions in the future. And then a real-world study in Zambia with over 150,000 couples, of which 26% were serodiscordant, really showed that couples-based voluntary counseling and testing is feasible. And it results in a higher reduction in HIV transmission at a relatively low cost, primarily because it improves disclosure between couples, and that was more effective in treatment as prevention because people may not disclose. There were a number of medical male circumcision studies looking at conditional cash transfers. What they really found is that even though the conditional cash transfer, that is giving money in order to, and in this case food vouchers, resulted in an increased likelihood with increasing amounts of money to result in men getting undergoing male circumcision, the likelihood was actually really low. It was actually only as high as 9%, and that was for 3 days worth of wages in order to improve that outcome. So it was statistically significant, but not necessarily clinically significant overall. Overall, acceptability of infant male circumcision was low. In a study of over 1,000 eligible male infants, only 13% of parents accepted either the Mogan clamp or the AccuCirc, which is a new methodology that can be done by non-physicians. Unfortunately, the study was done kind of late, but it was highly acceptable for parents who underwent this, but overall acceptance was relatively low. We did see in another study that male circumcision had extra benefits with regard to reducing syphilis incidence. There were differences for men and women. Most of the benefit in reducing syphilis by male circumcision for men was primarily in HIV-infected men, but it was a statistically significant benefit overall. But for all women, irrespective of their status, if their male partner was circumcised, it reduced syphilis, whether the women were HIV positive or HIV negative. I am going to sort of move forward and end with one sort of comment that came from Lorinda Garcia, who gave a sort of an individual perspective, and it's really the future of HIV prevention. So all of our microbicides and all of our PrEP studies and our PEP studies, etc., are important, but part of the sort of the future, if you'll forgive me for a second for borrowing some of his ideas, is that we need to do a lot of work structurally with regard to developing an intolerance vaccine so that we can change the laws, decriminalize HIV, decriminalize sex work and a number of other factors that are associated with contributing to our ongoing HIV transmission. He suggested that we also create a violence condom that we can put over ourselves when people who engage in sex work or who have HIV, who are subjected to laws, can shield themselves and protect themselves in that setting, and to come up with a post-hate exposure prophylaxis to really deal with the issues in society that are continuing to drive the epidemic. But the other piece that I added to this is that given the very level funding for prevention, especially using effective therapies, is we really need to do a lot with regard to increasing our funding and our advocacy on this regard, and certainly not separating out treatment and prevention, that the two of them are often linked and they should really become synergistically combined. I don't know if I'm able to take comments or questions, but I will leave it up to the organizers to see if we have time to do that.
Hi, Rick. This is Carlos. I want to present my apologies to the whole group. I had a family emergency and I thought could be here on time, but I was late. Fortunately, you guys started, although, I mean, again, my apologies, you started a bit late. Anyway, I think you've made a wonderful summary of Track C, and I'm happy that you had more time here than you had in the conference to present it and to really expand. I mean, it's a fantastic demonstration that people engaged in epidemiology are very much engaged in human rights and very conscious about the social, which is, it shows this is a new generation of people who are better trained into social issues and able to look at those very in great detail. Anyway, as it's late, we had a question from Anne Forbes about the study from Susan Casede on the difference between the trajectories of girls and boys. No? Why do girls have a different trajectory as compared to boys? Is it that they are not engaged in ART as in the same rate as boys?
Yeah. The disaggregation of that was really interesting, and what they were finding is that there was a large proportion of these young girls, primarily 15 to 19, who had sort of been treated as adults previously, who were newly infected, and so they were somewhat asymptomatic, and they were early on in the natural history of HIV, and so they weren't really getting sick and dying from complications of HIV, whereas it wasn't so high. These new infections were not high among the young boys, and so they were mostly represented as a sort of a birth cohort. So they were they had been living with HIV for 15 plus years, and as they were sort of approaching adolescence, they were falling out of care as they were becoming more and more independent, which was resulting in the increased mortality for them. Whereas a lot of the women, even though they might not have been in care, they were early on in their HIV trajectory with regard to natural history. And so I thought that was really, really important. If they control for just perinatally infected kids, that particular group, the 10 to 19, was no different between boys and girls, but it was the disaggregation of the new infections among young girls, starting at about age 15, that was really driving the difference in mortality.
Okay, excellent. I think this is really fantastic summary. The good news, not many of you know already, but we record these sessions and we make them available both through our mailing list and at the NEMUS website. So I think people, who didn't have a chance to see you or to listen to your complete report because you didn't have the time to present it at the conference can actually access it here and listen to you directly. So I think it's going to be a contribution to the conference too. Anyway, thank you again, Rick, and really thanks for your generosity being here this morning and making this summary sort of accessible to many more people. Our next meeting actually will have a new of the non-English language meetings by the end of the month in Portuguese, and we'll have another one in early September. We are actually confirming the theme and date very soon, and we'll be making it public through the usual means. Again, thanks very much. Apologies again for this personal family problem that I had, and actually thanks very much to you, Rick, and to all of you guys being here today. And we'll talk to you soon.
Carlos, if I could just add one thing that I'm happy to have these slides circulated to anybody who wants them. So if you or any of your colleagues want to make them available to folks, I've updated it since the conference. I slightly expanded it, and if anybody wants them, they're welcome to them.
Excellent. Please do so if you can send those to us, and we can actually send them to those who attended the meeting. And yeah, actually the recording includes your slides, so people who see you on our YouTube channel will be looking at the slides too. So thanks a lot again for that clarification, and talk to you all soon. Okay.
Thank you.
Take care. Bye.